Good morning, everyone. Thank you, Liz, for that introduction, and Jacob for a wonderful foundation for my talk. So I'm going to spend just a short time stepping through some of the major principles and take-home points with regards to radiation for the management of brain tumours. And as has already been said, it's a very broad group of tumours, and I'm going to give you some examples of where radiation is most used. So generally, radiation is a post-operative treatment, generally speaking. It has a role in high-grade glioma, low-grade glioma, but also benign tumours, including patients with meningioma and pituitary tumours, for example. But of course, it's very important to establish the diagnosis through surgery or through at least a biopsy for the radiation doctor to work out what dose is needed, how many treatments, where we're going to target the radiation is absolutely critical for us. So in the next few minutes, I just want to cover 3 or 4 key areas, and that is, how does radiation work pertaining to brain treatment? What are the benefits of radiation? What are some of the advanced technologies, and particularly imaging, that we can use to really precisely target the tumour area? What are some of the known side effects, and how can we mitigate or how can we reduce these, both short and long term? And what are some of the future directions on the horizon? So firstly, how does radiation work? A very important question, because most of us think of radiation from what we hear in the media. So it's got a pretty bad rap, obviously, in terms of radiation damage. But when we use radiation very precisely for treatment of cancer, and in particular brain cancer, it's usually delivered under a machine called a linear accelerator, or a LINAC for short. And as you can see, it's somewhat similar to a CT scanner, but a little bit larger, and it's sort of open. Patients lie on a flat couch, very similar to an MRI or a CT table. And the actual machine rotates around the patient. And very similar to having a chest X-ray, radiation for treatment is completely invisible. It's completely painless. The main difference is the energy of the radiation we use is much more powerful and penetrating to actually damage the DNA at a cellular level. So your next question is, well, doesn't radiation actually damage the healthy tissue as well as the tumour tissue? And the answer is the conditional yes. But the smart thing about radiation, and particularly when we give it over a course or fractions of number of treatments, is that we actually exploit the difference between normal cells and the tumour cells. So the tumour cells are abnormal in various ways, but in particular, they don't have normal repair mechanisms, whereas normal healthy tissue usually does. And so what radiation does when we give it over usually a 5 or 6 week course for, say, high-grade glioma or something like glioblastoma, is that the healthy tissues repair themselves over time, but the tumour cells do not. So really, radiation has been used as a very fundamental treatment, particularly for high-grade glioma, so grade 3 and grade 4 glioblastoma tumours, for many, many decades. And it really has an established effect in prolonging patient survival. And this is a very old table, a very old figure, showing that compared to best supportive care with steroids alone, compared to having chemotherapy, really the best outcome was achieved with radiation and chemotherapy. And in fact, some people in the audience would be aware of this very key paper published now in 2005 by the Europeans and Canadians, essentially looking at the backbone of radiation for 6 weeks in the setting of glioblastoma, compared to radiation and an oral chemotherapy tablet called temozolomide, or TMZ for short, showing that the combination of radiation and chemotherapy, patients fared better. And that is now the standard of care, and I'm sure Helen will speak to that as the backbone we currently use for treatment of glioblastoma patients. So it's important to realise, as I've already hinted at, that radiation is an extremely precise local treatment, so similar in a way to surgery that Jacob's outlined. So to achieve that, we actually need to immobilise the patient in what we call a thermoplastic mask. So as you can see, it's like a net. People can breathe through it, they can see through it, but it very nicely conforms to the patient profile, because we need to deliver the radiation within sub-millimetre accuracy, and we can't have the patient slightly moving even a little bit. We simulate, or we plan patients using a CT scanner, very similar to a diagnostic CT scanner, but with some additional aspects that we can actually plan the radiation. And there are actually some hospitals within Sydney, around Australia and overseas where we actually have an MRI fused with a simulator. So we can actually take all the detailed anatomical information that Jacob spoke about and fuse that together in our radiotherapy planning system for optimal targeting of the tumour area. And this is an example of a radiation, what we call a colour dose map or an isodose map. So if you're familiar with the weather dose map, you'll appreciate that the area of similar colour is where we're delivering the high dose. And if I were to point that out, this red is the high dose area where the tumour was removed, and around it we have surrounding low dose, but we really try and demarcate that area very well. And we actually take the preoperative MRI, the postoperative MRI, if a patient's had one, fuse it or merge it together with the radiotherapy CT, and we very precisely localise where the visible tumour is, if there's residual tumour, where the microscopic or invisible tumour is, we give that a margin, and we're actually very careful to shield or protect normal structures such as the brainstem, the eyes, the lenses in the eye, the optic nerves, all the very important structures so that radiation is safe and better tolerated. This is an example from a young patient aged 17, just to show you the degree of conformity or accuracy with which we can deliver the radiation. And as you can probably appreciate in the MRI, this is the abnormal tumour here in the brainstem. And again, another isodose map showing a very tight distribution of radiation dose, so the highest dose where we really need to deliver to the tumour, and a fall off of dose around that as accurately as possible. And again, another example from a younger patient, just to show you how precisely we can localise the radiation. And this is the target volume or the target area of radiation right next to the brainstem. It's actually pushing the brainstem to the right. But we actually achieve this, not only plan it very accurately, but actually when they're delivering treatment, so dynamically as the radiation is delivering its treatment, we can image the patient as we go along to verify that what we had planned is actually what we had delivered. Changing tack now to show you a patient with a benign tumour, meningioma, and very similar principles in terms of using MRI with beautiful anatomical detail to try and localise the area of the tumour, and very importantly to make sure that the brainstem and the optic chiasm, which is the crossing point of the optic nerves, and the lenses of the eye are all shielded and protected from the radiation treatment. So the question I want to pose is, well, what is the optimal time? In the setting of a patient with a high-grade glioma, that means grade 3 or grade 4 glioblastoma, how quickly do they need to start after an operation? And that's a good, very important and pragmatic question. I flagged just one now quite old study from Westmead Hospital here in New South Wales, which looked at patients with grade 3 and 4 glioma and actually counted sort of the wait time from the time of biopsy or surgery to the time they started radiation. And importantly, showed that patients who are slightly older, who had a slightly lower dose of radiation and who actually waited longer. And remember, this is in the setting of the time in New South Wales and Australia where there was quite a significant wait time for radiation, perhaps 6 or 8 weeks more. They actually fared worse. So I think the take-home message is not to cause anxiety, but it is important that once a patient has healed post-operatively and they've recovered, that one sees the radiation oncologist to plan the radiation, and the radiation is undertaken in good time after surgery. So what then are the side effects of radiation? I've already detailed to you that it is a very precise, localised treatment, but nonetheless, of course, there are some potential side effects, and I list here some of the common ones. So during the 5 or 6 week course of treatment that we would give for a patient with glioma typically, most people do experience some degree of fatigue. It may be mild, it may be moderate. It actually builds up, as you can appreciate, through the 6 week course of treatment. It peaks and then it usually resolves, and it takes a variable amount of time for it to resolve. And I always encourage my patients to exercise, to be as physically active as possible. I know the old paradigm is to sit at home on the couch or in a chair, but really the new paradigm is to be as physically active as possible, and that really helps post-operative recovery, helps circulation, etc. There is some patchy hair loss in the treatment area, so about week 3 or halfway through the course of treatment, I tell my patients expect that your hair will fall out or molt in a patch. It may regrow, but it can take time to regrow, as in a number of months. I would say that about 1 in 10 or 1 in 8 of my patients can experience some raised pressure symptoms. So by that I mean headache or potential for nausea, but these are things that are very predictable, and we obviously make sure that patients have anti-nausea medication or appropriate medication to take to prevent those side effects. After treatment, that is in terms of the medium term, people still feel fatigued, and that is something really that time and exercise, physical activity is going to help relieve. And as I think Jacob already highlighted, there are some longer term side effects, not just of radiation, but of people taking steroids. There can be some effects on endocrine or hormone function if the pituitary gland is near the radiation area. I'm going to talk for a few minutes about cognitive function or thinking or memory processes. So we do know that if we follow up patients over a long period of time, and this is a European study looking at patients with low-grade glioma, and they follow them up long-term. So in fact, they follow them up for 6 to 28 years after treatment, so many decades after treatment. They did appreciate when they did very specific neuropsychological testing that patients did have changes in their cognitive function, including executive function, which is like multitasking, memory, all the things that we take sort of for granted and do in our everyday life and work, etc., and also their attention. So we do appreciate that radiation, when given for a good reason to control tumour, does have the potential for late side effects, particularly in the setting of, say, low-grade glioma or benign tumours, and therefore we do our best to either avoid radiation, defer it for as long as possible, particularly not treating children or adolescents, but also to really minimise these effects. And now with modern technologies, very precise targeting, we can reduce the area of radiation as much as possible. I want to give you a little bit of a story about the hippocampus. You probably don't know that the seahorse is my favourite animal, and I've been collecting seahorses for 20 years. So I was very delighted to realise that the hippocampus is actually an area of the brain, and some of you might know that the hippocampus is sort of the Latin or Greek name for the collection of seahorses. It's actually located in the right and the left side of the brain, in the medial temporal lobe of the brain. And it plays a very important role in consolidation of information, the laying down of short-term and long-term memories, and also what we call spatial navigation. And in Alzheimer's disease, as a type of dementia, it's interesting that the hippocampus is one of the first regions to suffer damage in that particular setting, so that memory loss and disorientation can be some of the symptoms we see as Alzheimer's disease progresses. So people have done studies both in animal models, in rats and in mice, looking at what is the effect of radiation when it's given to the hippocampi in the brain. In fact, that we appreciate that there are learning and memory deficits that can occur and that can affect the brain at a cellular level, even with small or low doses of radiation. So the obvious question is, well, can we avoid the hippocampus when we give radiation? And there have been a number of clinical trials done across the world, particularly in the setting of patients who have secondary brain cancer or brain metastases, and there's an indication for whole brain radiation. And can we actually deliver the radiation, not compromise treating the tumour successfully, but can we actually avoid the hippocampi so that we can preserve people's neurocognitive function, preserve their memory, preserve their learning processes? And indeed, we do have evidence, and there are ongoing studies, and we are actually using this in clinical practice, particularly with this in the setting of brain metastases, to achieve exactly that. And this really is a colour dose map of what we call hippocampal avoidance. And again, it's used in the setting of whole brain radiation, so not necessarily for patients with glioma or benign brain tumours. And this particular area here on both sides, the grey area is actually the hippocampus that's been drawn out, and the green area around it is an extra buffer region. And we see that the radiation dose is actually, in the yellow, successfully able to sculpt around the hippocampus for improved, hopefully long-term cognitive function in patients. A further few questions as I close. Is a further course of brain radiation possible? Well, in the majority of patients, it's not actually required. But there are certain factors or things that we consider for patients who may well require a course of radiation. It's a case-by-case discussion with the specialist team. It depends on the side effects involved, how fit the patient is, and where the tumour is that we're targeting in relation to the first course of treatment. So we can achieve that through very precise, what we call stereotactic radiation treatments, which is very precise positioning in three-dimensional space, and we can deliver that through special machines, either through the standard LINAC or through something called the gamma knife, which is a different type of setup where radiation is very precisely delivered to a brain target. So just in closing, 2 final slides. I've tried to just briefly summarise some of the benefits of radiation. We do know that it's a very important treatment, particularly for patients with glioma and selected benign brain tumours. In glioma, we know that there's a significant life-prolonging effect. There's some common questions that I've tried to address regarding some of the short, medium and long-term side effects. timing of postoperative radiation is important, as extensive delays can compromise the outcome for the patient. Repeat courses of radiation are possible, but we have to be very selective in patients that would best benefit from second course radiation. And I've tried to sort of weave a theme about the advances in technology, which really help us precisely delineate the radiation target and therefore can improve short and longer term effects of radiation, particularly hippocampal sparing. And so what does the future hold? I think the technological advances in radiation parallel those to neurosurgery. Radiation will still remain a fundamental treatment in brain tumour care. And to hand over to Helen for the next baton and her talk, it's very important that radiation works synergistically with chemotherapy to improve outcome, particularly in the management of glioma. Thank you very much.